This presentation is over transthoracic echocardiography and the focused assessed transthoracic echocardiography assessment, or the FATE assessment. Ultrasound is the only method which enables real-time bedside imaging of the heart, and focused assessed cardiac ultrasound provides very diagnostic information to bring about changes in the perioperative management. TTE allows rapid, non-invasive, point-of-care assessment of ventricular function, valvular integrity, volume status, and fluid responsiveness. The FATE exam is an abbreviated protocol for the full transthoracic echo protocol and is an effective supplementary tool to physical examination and intuitive thought. It offers a very systematic and focused approach to the echocardiographic examination and proposes a skill set that can be very readily and quickly learned. Objectives of this presentation are to discuss the basic physics of ultrasound used in the FATE exam. As well, we're going to list the 4 basic cardiac questions answered by the FATE exams. Things such as causative pathology, contractility, estimation of wall thickness, chamber dimensions, exclusion of pleural pathology, etc. We're also going to describe scanning techniques and positions used to acquire ultrasound views for the FATE exam, and identify the 6 basic transthoracic echocardiography or TTE views used in the focused assessed transthoracic echocardiography exam. So just to go over a little bit of basic ultrasound physics without putting anyone to sleep, sound's a mechanical wave which requires a medium in which to travel. More accurately, it's a series of pressure waves propagating through a medium, and the speed with which an acoustic wave travels through a medium is determined by the density and stiffness of the medium. The greater the stiffness, the faster the wave will travel, and some of the correlations to this are sound waves travel faster in solids than liquids or gases. For the purposes of what we use ultrasound physics for, sound waves are emitted by the piezoelectric materials or crystals in the ultrasound transducer probe. This electrical energy is converted to sound waves by the transducers. These sound waves reflect from tissues or objects, and then returning sound waves are converted back into electrical energy, and an image is created. Key parameters of ultrasound waves include frequency, wavelength, velocity, power, and intensity. So once again, the down and dirty of wavelength and frequency. Wavelength is the distance between points of maximal amplitude of the sound wave, and the frequency of a wave is the number of wavelengths in 1 second, or hertz, and the range is about 1 to 15 megahertz for medical ultrasonography. Human audible sound ranges between 16 hertz and 20,000 hertz, or 20 kilohertz. The frequency and wavelength are related to the velocity of the ultrasound beam. And as far as how it affects us, the higher frequency, short wavelength ultrasound waves can separate objects less than a millimeter apart. So things that are very close to the surface, that you're wanting to get some very good delineation of structure, such as arterial line, venous, IJ for a venous line, it's a very, very good frequency. So how does this relate to transthoracic echo and perioperative point-of-care ultrasound? Well, higher frequency transducers, such as a linear array probe that you may be used to using for lines and maybe some blocks, offer enhanced resolution. The depth of penetration is inversely related to the frequency. But while you get very good delineation of structures, superficial structures, at more shallow depths, you have reduced tissue penetration. Hence the need for use of lower frequency transducers, such as the phased array probe that we use in cardiac, which offer better penetration but lower resolution. The different types of imaging, there's two-dimensional or 2D imaging or brightness mode, which is the most commonly used, which provides structural information utilizing different shades of gray. As you can see in this image over here on the right, this is where your transducer is. It sends out the image bounces off a structure, and based on the perpendicularity to the transducer probe, it's going to come back with different degrees of resolution. And then if you have anything closer to the near field, what's the closest thing in the near field to the point of maximal impulse? It's going to be the apex of the heart, so it's going to be showing up like this, such that this is the left ventricle, this is the right ventricle. So you're kind of seeing like a mirror image of it, which is a little bit confusing. The majority of ultrasound imaging is accomplished using B mode or 2D mode. So you get, if you have no sound wave reflection, or if it's dark or anechoic, things that don't really reflect very well are things like blood, bile, urine. And as you can see in this image, in this left ventricle here, you see it's very anechoic. You don't get anything coming back to you, so you know that that is the chamber of the heart. However, instead of seeing a nice bright pericardium, which really is very echolucent or hyperechoic, you have this nice anechoic area here, which in this particular case is cardiac tamponade. Relatively few waves, few sound wave reflections are like hypoechoic, such as the renal cortex. If you've done the FAST exam or a right upper quadrant exam, you may have seen this. Reflections similar to surrounding structures, isoechoic, or solid organs and tissues. And that's where you get kind of a different shade of gray here from the right ventricle, left ventricle, inferior wall of the left ventricle, anterior wall of the left ventricle, free wall, and the left atrium, aorta, aortic valve. In reflection of almost all sound waves, it's hyperechoic. If this aortic valve is very sclerosed or calcified, you'd see this very hyperechoic structure. M mode is a little bit different mode compared to the brightness mode or B mode, and we use M mode a pretty good bit when it comes to looking at very active, very hyperdynamic structures, such as the left ventricle. If you're looking at changes over time, such as what happens to the IVC during ventilation to gauge volume, M mode is very useful for that. But it analyzes the movement of structures in a small sample of time. And then Doppler imaging is a very complicated mode that follows a very sophisticated and complex law of physics. It utilizes a phenomenon called Doppler shift, which is a change in frequency from the sent to the returning sound waves. And these shifts or changes are generated by sound waves reaching moving particles. So this change in frequency, their amount of shift, correlates with the velocity and the direction of the particle motion, such that you put some Doppler imaging on using sound waves in Doppler mode, you're going to get, depending on the color, velocity, and depending on the color, the direction of the flow. So again, it's a lot more complicated than a single slide, but a more utilitarian approach is what I'd like to offer in this presentation. Basically, the effective tissue on ultrasound occurs in several ways and artifacts. You have reflection, where tissues having different acoustic impedances reflect a portion of the signal, with perpendicularity affecting the signal quality, which is what we are very much dependent on when we're talking about reflection off of, say, a mitral valve or an aortic valve. Refraction, you have tissues with different acoustic impedances which refract or bend the ultrasound beam if the interface is oblique, which is going to affect the quality of the signal. You have scatter, where small structures and non-homogeneous tissues scatter the ultrasound signal, so it's not a very discrete tissue interface. And attenuation, as the signal travels further from the transducer, the signal loses strength and reflected signals are weaker. And this is kind of what you get when you start to talk about deeper structures further away from the skin and the transducer. Transducer movements are all related to getting perpendicularity to the object or region or structure of interest. Tilting the transducer is kept in the same position and moves side to side or heel to toe. Pretty much the transducer is kept in the same place on the chest and moves side to side to allow other planes in the same axis to come into view. Rocking, tilting in a perpendicular plane of motion toward or away from the transducer orientation marker, or the little dot, or the OM, or line, or whatever you want to call it. But pretty much the transducer is kept in the same place on the chest and moves cephalad or in a caudal direction. Sliding, a transducer is moved to any position on the chest wall. It's also known as translation. Transducer is moved on the chest to any position to obtain the best window and in any direction. For instance, sliding the transducer from parasternal to apical area. I think they call it like dropping off the cliff when you're going from parasternal short axis to apical forward chamber. And then finally, rotation. The transducer is left in the same position but rotated clockwise or counterclockwise. It's done for obtaining different views for the same echocardiographic window. Rotating the transducer from 11 to 2 switches from long to short axis. This is very similar, if you're used to doing transesophageal echo, to hitting your Omni button. There are several different types of probes that are used, and these transducers consist of the active element, the piezoelectric crystal, a damping material, and a matching layer. Different arrangements and forms of activation of the active element have led to a variance of the probes. The most commonly used ones for FATE, FAST, the RUSH, FICE, FOTE, whatever you want to call it, are sector probes. These probes are some examples are the linear probe. This is typically used for vascular airway. This is higher frequencies and resolution for superficial scanning. Phased array, you have lower frequencies for more depth. You have a smaller footprint to get between the ribs. I like the phased array a lot. I think that since I'm doing a lot more abdominal chest wall scanning, pelvic scanning, I've gotten to where I have an appreciation for the curvy linear because you can get underneath structures and you have a larger field of view. It has very low frequencies with very large footprint, very good for the abdomen. So here's cardiac ultrasound. Cardiac ultrasound can be extremely complicated, and to that end, it's not something that you want to try to start out with doing in a routine version of the FATE exam. But true cardiac ultrasound has 20 different views as far as transthoracic echo goes. Transesophageal echo has 28 views, and it can get extremely complicated. But we want something that is high utility. We want something that does not slow down the process of what we're doing in the operating room. That's why it's called perioperative point-of-care ultrasound. It's an abbreviated version of everything, but it's a very focused exam and gets you the information that you need. It should be used as well in conjunction with other bedside assessments, and these include your own intuitive thought, empiric judgments, some of the things that you just know. For instance, you just know you need volume, but you just have given a bunch of volume, so it's used in conjunction with what your knowledge is of what you should be treating the patient with. It also offers repeatable real-time interpretation of cardiac anatomy and performance. And with some of the new handhelds, and don't get me wrong, the handhelds are not as good as the consoles, but they're getting there. But with the evolution of the handhelds where you can just pull something out and read it right off your phone, I mean, what more could you ask for? But at the same time, perioperative ultrasound often involves a console and often involves collaboration with the surgeon, especially if you can't really get to the chest with a transthoracic echo probe. But of these 20 views, the FATE offers an abbreviated version, typically incorporated 6 different positions and 4 different cardiac views. And these are used for screening and cardiopulmonary instability. And then, of course, you can take it as far as you want. I mean, once you start scanning and you get your hand on how to find the aortic valve in short axis, if you can find the aortic valve in subcostal view, whatever you end up using it for is just an extension of what you want it to do. But through the FATE, the FATE pretty much aims at comprehensive assessment of hemodynamics, Doppler ultrasound, diastolic dysfunction, severity of heart valve diseases, and even more. But again, this presentation addresses the basic FATE protocol. So what is the FATE exam? In the FATE, we're not trying to do 20 views. We're not trying to become cardiologists. We are trying to make some assessment of cardiopulmonary instability and ask some very distinct questions here. But there are 4 basic ultrasound or transthoracic echo positions. Position 1, you are going for the subcostal forechamber, which is very easy to do. You find the subxiphoid just like you would do if you were about to start CPR, and you basically stick it underneath the subxiphoid with an overhand grip, and you point toward the left shoulder. You get all 4 chambers, which is very nice, but also you get a nice view of overall contractility of the heart. You get to look for an anechoic region, as you would see with a tamponade, things like that. The second view is the apical forechamber, which is going at the point of maximal impulse down here at position 2. And some people like to start out with a parasternal short axis and slide down to the apical 4, but this is not typically what's done in a normal FATE protocol. Parasternal long axis is position 3. You're going to line the probe up just to the left of the sternum or parasternal and point the orientation marker or the dot to the right shoulder. And then the parasternal short axis, you're just rotating 90 degrees and pointing it toward the left shoulder. And you get a nice short axis view of the heart and its filling and contractility. And then the other views, the position 4, which is really ends up making it 6 views, are the pleural views, where you're looking for pleural pathology. So through these different positions and assessments, you can assess biventricular function. You can look at both the left and right ventricle in the parasternal short, often the parasternal long axis, but certainly the subcostal forechamber. You look at valve function, where you're looking at things such as the mitral and tricuspid and aortic valve. You look at volume status by looking at the LV and RV, but also at the IVC, which we'll look at momentarily. You're looking for an effusion, whether it's pericardial, like a tamponade, or a pleural effusion, and we're going to exclude pulmonary pathology by looking for A and B lines. So what is the utility of the FADE exam? Well, we can monitor and treat unstable patients, doing things such as estimating preload, estimating contractility, estimating heart chamber and wall dimensions. And a lot of the preload and contractility assessments have to do with Ohm's law, which is simply blood pressure equals cardiac output times SVR. So if you know that the blood pressure is down and you look and see that the contractility and the preload is down, you know to give either volume or a little bit of contractile drug, ephedrine. If everything looks good with your preload and your contractility, maybe it's time to give an SVR drug. It can be as simple as that if you want. You can also look at the heart chamber and wall dimensions, and you can make assessments such as global function. You can look at whether or not your heart's overfilled, you have some taco or circulatory overload. You can also look at wall dimensions and look for things like, well, you got a very thick ventricular wall. Maybe you have a need for higher blood pressure, and that's what the issue is. Maybe you got some IHSS or HOCA. An abbreviated two-dimensional cardiac ultrasound offers these assessments, and that's what the FADE is for. And the FADE typically offers useful information in about 97% of the ICU patients, according to Homenthal, and a 3-hour training course with 5 hours of hands-on training are sufficient. And typically, for example, the Society of Critical Care Medicine every spring offers a training course on the FADE exam, and about a third of the participants there are advanced practice nurses. So some essential foundations for ultrasound and transthoracic echo. The phased array is the preferred transducer for the FADE exam because you're getting a lot of cardiac windows, and that's the learning curve here. The different positions, what you're seeing is nothing compared to learning how to get the windows, which involve a lot of rocking, tilting, sliding, and angulation, etc. You use lower frequency wavelengths for the deeper structures. Typically, it's about 16 to 24 centimeters in depth. Higher frequencies used for more shallow structures, so you might end up changing your depth settings a little bit. Some people even like to use a linear or even a curvilinear probe. The three basic modes, again, B mode, motion mode, and color flow Doppler, where you can see direction and velocity. And the things you basically see, this is actually an apical forechamber from your PMI, which is right below your left nipple in men, as we learned a long, long time ago in a galaxy far, far away. You're going to see that this is the near field. There's the transducer right here, and you're going to see the apex of the heart, which is right here closest to the skin. You're going to see the LV and the RV, the mitral valve and the tricuspid valve, along with you can look at the size, the chamber dimensions, and the wall dimensions, and you can look at the filling and contractility. So far we've talked about 2D imaging and motion, or M mode. Another mode that's very, very useful, especially if you're trying to rule out some gross valve abnormality, is Doppler imaging. Doppler imaging and color flow mapping are pretty much synonymous, but Doppler ultrasound provides direction and velocity of flow. Moving objects change the frequency of returning sound waves, and the shift in frequency is determined by the velocity and the direction of the object. So for each sample volume, the ultrasound machine assigns a color for the average Doppler shift, such that flow away from the transducer is coded blue, blue away, and then blood flow towards the transducer is red, so red towards. So blue away, red towards, or BART. And it gets kind of confusing if you've been doing a little bit of cardiac, or you've been around some transesophageal echo, you see mitral regurgitation always colored as red, so you think red equals regurg. Well, that's not the case at all, especially in transthoracic echo, because you're looking, especially in an apical four-chamber, mitral regurgitation is going to actually be blue because it's away from the transducer, which is on the skin. So instead of an inside-out measurement that you get with TTE, it's outside in. So you have a different color flow pattern. And also, along with a different color, a different degree of color tells you about the velocity. So the higher velocities are a more intense shade of blue, so that it's more teal, and then a higher flow towards the transducer actually goes all the way up into yellow. So if you really have high velocity, and you see that a lot, especially with mitral insufficiency, it's almost a yellowish color. So along with finding the view, which is pretty darn difficult to do until you get the hang of it, knobology is something that's just extremely intimidating. And it actually, at least in cardiac ORs, it almost queers you to the point of not wanting to even look upon the evil transesophageal echo probe. But there's a few knobs that you absolutely have to get the hang of. Believe it or not, the on and off button is difficult. I mean, it may be marked on and off, but you can't really tell because it takes a minute for the ultrasound machine to boot up. And some machines, the CX50, the Philips CX50 that we have around, takes up to 4 or 5 minutes to completely boot up. So really we have it on at all times if we're doing like a laser lead extraction and we're worried about an effusion. Some of the quick keys, which you have mentioned here, see here listed, are not very intuitive at all, and you have to learn what each one does. So if I've got it highlighted in red, it's stuff that once you turn the machine on and have it up and running, these are the only knobs that you really need to fool around with, to be honest, for the FATE exam. And if you decide to and really become you really take a liking to what you're doing, you might want to explore the rest of the console because it really is cool stuff. But the gain knob is number 3 here as listed, and it actually, you turn it clockwise to increase the gain. The problem with increasing the gain is you're going to change the overall strength of returning echoes and amplify the signals, but sometimes you amplify them so much that you lose some of the resolution. The depth adjustment is very important because it's not the same as zooming. Depth is going to actually change the depth of your ultrasound sound waves, and that's going to change a lot of what you see and the resolution of some of the returning structures. It's going to increase or decrease the depth of the ultrasound beam. The zoom image is actually going to let you focus in or zoom, and that's something that if you really wanted to zoom in on a structure, that's what you use. You don't change the depth. Color imaging, this is Doppler. You're just hitting on the color button and you're getting a nice little Doppler window, and you manipulate the Doppler image with this little trackball down here. You're just kind of manipulating a trackball, and you're hitting this little mouse button here and changing between modes to manipulate the window. You're not really going to freeze the image or acquire the image typically unless you're doing a study. The caliper is very, very useful when you're talking about measuring the IVC. If you're going to measure the walls of the LV or the walls of the RV as far or the chamber, just to kind of get an idea about whether or not the heart is large. And instead of just eyeballing things, you can actually measure these, and there's several nice little apps that you can stick on your phone. You can very quickly dial up what the appropriate size chamber is and get an idea about ventricular hypertrophy, for example, whether it's chamber or wall hypertrophy. So again, this is the simpler, this is the simplest console in the world. This is the Philips CX50, which is more like a laptop computer. So imaging artifacts. Imaging artifacts are inaccuracies of the true appearance of the image structure. On the other hand, often when you start talking about the FAST exam, and when we start talking about some pleural imaging artifacts, these actually help in our diagnosis or assessment of the patient. But image artifacts are grouped as a degraded image, and that has to do with gain, electrical interference, air. These are things that the bovie can interfere with your scan, which was very painful. Air, if you're doing a transesophageal echo, rather, if there's air in the esophagus, that's going to mess up your imaging. Missing structures, focus, dropout, acoustic shadowing. In this particular scan on your right, you can kind of see the dropout that occurs from a prosthetic aortic valve, because obviously there's not going to be a lot of sound transmission through the metal. Mirror artifacts, which is an erroneously perceived structures, mirror artifacts are very useful in the FAST exam in looking at the liver and the mirror image in the lung, because the lung is just air. It doesn't really reflect anything, but you can actually, if you have an effusion, you're not going to get the mirror image artifact. And then directional ambiguity using Doppler can be erroneously perceived as well. And finally, mislocated structures, the side lobe and beam width artifacts, are things that can really mess up your scan as well. On the other hand, some things, comet tails, such as in B lines in the lungs, if you're looking at reverberation artifacts, as you see if you're doing some scanning in the airway, these are actually very useful, especially if you're looking around for things like the cricothyroid membrane. So using the FATE protocol for hemodynamic and pulmonary instability, cardiopulmonary instability is assessed in 5 steps. You're looking for obvious pathology. You know, if you've seen a few scans and you see that the LV is just not beating very well, for example, or if you put some color on and you see some MR. Then you look around for wall thickness, chamber dimensions. You think, man, that's a big heart, or that's a very thick left ventricle. You also look for biventricular function. Sometimes you have RV dysfunction, especially in people with pulmonary embolus, especially in people with hypoxemia. There's a lot of patients with pulmonary hypertension as well, obstructive sleep apnea, obesity, hypoventilation syndrome. You're visualizing the pleura on both sides. If you have some nice A lines, it's one thing, and we'll see these in a moment. B lines, it's another. If you've got, if your pleural line is not moving at all, you worry about pneumothorax, things like that. And we'll look at these in just a moment. And then you're going to relate the information to the clinical findings. I mean, we're not just sonographers. We are clinicians first, and then we're using sonography to reinforce our decision making. So we're going to start scanning from the first position, which is the subcostal forechamber. This is a very convenient position for us because patients flat on their back. We can typically reach right underneath the subxiphoid, and typically it's an overhand grip compared to a pencil grip, which is what you may be used to using if you've done some scanning already. And then you're going to push down, and then you're going to redirect towards the left shoulder, the index marker pointing towards the left shoulder at 3 o'clock. You're going to adjust the sector depth to about 16 to 24 centimeters. If you think about it, it's about 5 inches up into the heart. And you're going to, if the patient's awake, you get them to breathe out or breath hold if you got the ventilator on, and you're going to visualize the position of the heart, and you're going to direct the beam. It's a very nice view. It's my go-to view, especially if I'm in a hurry. So this is position 1, subcostal forward chamber, and on the left side of the screen you've got a 3D image. You can see what you're scanning, and on the right you see a 2D image, and you've got liver here, which is a very nice acoustic window. Transducer's up here at the top. Okay, you're looking from, it's kind of an upside down image, but you're scanning from the subxiphoid towards the left shoulder. So you've got a liver here. You've got pericardium, which is kind of nice, hyperechoic structure, unless you got an effusion, and then it's nice and anechoic here. And then you've got the RV, which is actually a little bit more anterior to the LV, anterior wall of the LV, and then you're going to have the mitral valve, tricuspid valve, right atrium, left atrium, intraatrial septum. And you can see things much better here because, of course, this is just a simulator. But in general, you're going to have the liver as an acoustic window. You see contractility. The RV is about half the size of the LV, which is very good. If this is not half the size of the LV, either the RV is dilated or else the LV, if it's more than twice the size of the RV, you've got some degree of LV dysfunction. So some of the things you ask yourself in this view, and this is another 3D view on the left side, is there pericardial fluid or tamponade physiology? In other words, do you have any anechoic regions around here? Is the LV normal size and contract normally? And it looks like you put your finger in the middle there, about half the volume's ejected, and looks like all the walls move, septum moves normally, the RV's normal size, the left atrium and right atrium actually normal sized, and the intraatrial septum is moving normally. If you had some degree of an ASD or right atrial hypertension, like with mitral stenosis, the atrial septum would be bulging over into the left atrium. And you looking for your mitral apparatus here. You can always put a little color on here as well and see if there's any flow through the mitral valve during systole, which would tell you that you've got mitral insufficiency. So some of the key points in the subcostal forechamber, and this obviously, if you look at the 2D image on the right, you can see you got a little tamponade. You see the right atrium's collapsing, the right ventricle's collapsing, and the LV's underfilled. You look for an effusion. Excellent views of all four chamber dimensions and contractility. This is a very nice view for me because it's really cumbersome if the patient's awake to get them to turn on their left side. If they're intubated and asleep, they're flat on their back anyway. So it's difficult to get the apical forechamber compared to the subcostal four, which we see here. And this is, again, the best overall view in the supine patients. This is what they teach the EMS guys, because you can actually get this view when you're doing CPR. So it's a very nice, very down and dirty view of all the chambers. It tells you a lot about whether or not something really bad is going on. Okay, so same position, but instead of having the orientation marker pointed towards 3 o'clock, you've got the orientation marker pointed directly towards the head or cephalad. So all you're doing is you're just going to change the position of the transducer. You're just going to rotate the transducer. Same supine position, index marker pointed towards the xiphoid or at 12 o'clock. Same sector depth. You're going to breathe out and visualize the right atrium and hopefully find the IVC, which shouldn't be very difficult, but typically you've got to aim a little bit towards the patient's right. And this is your subcostal inferior vena cava view. You've got the beam, as you can see here, going straight up and down. And what you get from this beam is you've got the liver, you've got the hepatic vein, and you've got the IVC, you've got the diaphragm down below, you've got the right atrium. So depending on the state of volume, you can actually measure the width of this IVC, which should be 1.5 centimeters or so, and whether or not the IVC collapses during inspiration. If it collapses more than 50%, your CVP is typically either euvolemic or hypovolemic. So in this view, you can see you've got the right atrium here, you've got the IVC, and what you've got is you've got the liver as a nice acoustic window. So here you're going to measure the IVC, you're going to assess the IVC collapsibility, you're going to compare it to the LV size and obliteration of the chamber during systole, and this also gives you an idea about responsiveness to volume administration. So you measure the IVC diameter, it's less than 2 centimeters, and it's greater than 50% collapse during sniff or during a big positive pressure breath up to about 20 centimeters. Your CVP is 0 to 5, and it's a good time to get some volume. If it's 2 centimeters or more and greater than 50% collapse, it's 5 to 10. So anywhere between 0 and 10, you get less than 50% collapsibility. But if you get very minimal collapse and it's greater than 2 centimeters, your CVP is 15 to 20. And if you get no collapse and it's greater than 2, it's greater than 20. And I got a couple of examples here in just a moment. But again, you think, well, this looks pretty darn complicated. Actually, a group out of Vanderbilt University Medical Center, advanced practice nurses working in the ICU, they were able to generate the correct view with the correct assessment 86% of the time. So I think that this is not something that is not doable at all. So here's an example of hypovolemia. You can see you've got your beam going straight up and down here. You can see also the IVC is collapsing a whole lot. And so what we're going to do here is we're going to get a nice little M-mode measurement. We're going to measure this, and this is 1.5 centimeters. And along with the collapse that you're seeing here of greater than 50% for sure, I'm saying that's some hypovolemia. Same view, and this time we're going to get a nice M-mode measurement, and we're going to measure graphically. We're going to show you what happens, and what you see is you see the collapse down here. You've got the IVC between breaths and then during breaths, and you can see this is much greater than 50% collapse. So I'm saying that you've got some severe hypovolemia here that should be responsive to some volume. And this is literally going to help you with your decision making. Here's a patient with hypervolemia in this patient that's got a little bit of heart failure. You see your beam, and you can kind of see the measurement here. It's about 2.7 centimeters. And it does not collapse during ventilation. As well, it's greater than 2 centimeters. In fact, it collapses absolutely 0, so you know your CVP is at least 20. So that probably indicates that your LVEDP is high, which means that you probably need some type of contractility assistance. So some of the key points for the subcostal IVC, it offers a very high degree of specificity for volume assessment after a quick subcostal four-chamber. You just rotate it 90 degrees. A sniff can be substituted by a 6 to 8 cc tidal volume or 20 centimeters in holding in an intubated patient. And an IVC measurement yields very good volume information. Hypovolemia less than 1.5 centimeters with collapse of greater than 50%. Hypervolemia if it's greater than 2 with no collapse at all. It's just a couple of yes or no answers there. Second position is the apical four-chamber, and you're going to position the Transthoracic Echo transducer in the 4th or 5th intercostal space, which is just below the left nipple in men. With women with large breasts, sometimes you have to get a little bit creative, and in fact, often I will slide down off the parasternal short axis to just above the left nipple in women with large breasts. But again, this is the most difficult view to get for me, and I'm sure it's going to be for just about everybody. But basically, you're starting at about the mid-clavicular line or at the point of apical pulsation. The index marker is pointed towards the left or the axilla, and usually it's best if the patient's in the left lateral position. So how many times are you on your left or in the left lateral decubitus position in the OR? Maybe in the PACU. But you adjust the sector depth to a little bit less than you did with the subcostal. Instead of 16 to 24, it's 14 to 18. And if you really want to get a good look at the LV apex, it's going to be a little bit more shallow than that. And this is an apical four-chamber view. You can see where your beam is on the left in the 3D image, and on the right you can see the structures. You've got a nice view of the apex of the heart. You've got a lot like the subcostal, but it's kind of rotated a little bit, but you've got a nice view of the RV and the LV. This probably, for me, it gives me the best view of the mitral valve and the tricuspid valve, which is what I'm looking for, along with the atrial septum. So you can see the mitral valve there. You see the leaflets coapt very well, the tricuspid valve leaflets coapt. If I'm suspecting some type of bidirectional flow or MR or TR, I'm putting a little color on there, and I'm looking for it to be blue because the transducer's up here. The color is going to be blue back this way. And we'll look at some pathologies in the next presentation. Some of the information that you're looking for, again, you're looking for that tamponade physiology, but also you're looking for an anechoic region. You're looking for pericardial fluid. Is the LV normal size and contracting normally? And the answer to that is yes. It's about twice the size of the RV. The septum's moving normally. The RV's moving well. The free wall of the RV is something I often look at, and I could probably gain this up a little bit more and have a little bit better view. The LA and RA are normal sized. If they're under 4 centimeters or so. Often if the LA is large, you suspect some pathology, including mitral insufficiency, maybe even mitral stenosis, although you don't see a lot of that unless you have a prosthetic valve. So some key points with the apical four-chamber. Again, it's very useful in determining RV function, and if you're looking for a PE, the RV is not going to be working very well at all. Usually with a PE, we'll show you momentarily, the RV is not moving, but the apex is pretty well preserved. You're looking at valve function, you're looking at coaptation, and then again, Doppler is very useful for assessing tricuspid and mitral valve dimensions. Our third position is the parasternal short axis. We'll also be using the parasternal long axis off this. I love the parasternal short axis. In fact, this is the view that I get on any patient that doesn't have any type of report about their ventricular function, or if I think they're an NYHA class 1 or class 4, depending on the day. I'll stick a probe on it and with my handheld and get a quick view. And it just so happens that it's a very good view for me in my Philips Lumify. But in the 3rd, 4th, or 5th intercostal space, Hearts are sometimes very large, different positions of the patient. I used to think it was the third or fourth, and I wound up going a lot lower in my patient population because a lot of patients I take care of have lower ejection fractions. But it's the left parasternal border, hence the parasternal view, and you tilt or slide as needed. And this is a very difficult thing to do. Probably the biggest or steepest part of the learning curve with TTE is learning how to slide and angle. And typically the sector depth's about 10 to 16 centimeters. And this is a parasternal axis view. You can kind of see the beam on the left in the 3D image cutting directly across the heart. And you can see also you got a nice thick ventricle. And some of the things that you see in the ventricle, you see the anterior wall here. Again, this is the chest wall. So the anterior wall is going to be on top. Anterolateral is over here. Infralateral, inferior wall, infraseptal, and intraventricular septum. So you get a nice chop right through the middle of the heart. If you've got the papillary muscles there, you know you're in the middle of the heart. If you've got the mitral valve, which looks like a fish mouth, you know you need to angle a little bit more caudally or towards the foot. And then there's a nice view of the RV as well. I've got one clip of an Eisenmenger patient that, of course, you don't keep these things, but the RV took up just about the entire screen, and the LV was just a little smidge because the RV was so huge and such a dominant chamber. And here's a different view of the short axis, but what you've got is you've got papillary muscles here in this 3D image, and over on the right you can kind of see the 2D image, and the things you look at is the LV contracting normally, and literally I put my finger right in the middle of the screen and I watch the walls contract toward me, and if I've got good wall motion towards my hand, I know that I don't have any infarction or ischemia, and if not, I know I've got a regional wall motion abnormality. And then if my EF is 50%, it's great. And we're not trying to say, oh my goodness, the EF is 47.6%. We're trying to say good or bad, yes or no, black or white, ephedrine, neosinephrine, volume, no volume, things like that. Is the RV larger or smaller than the LV? And is the RV D-shaped and take up the whole screen? That kind of tells you that your RV is dysfunctional. And then, of course, you can also look for effusion and tamponade. But for me, this is the money view for me because it tells me whether or not I need to give half the big syringe or all the big syringe. This is the parasternal short axis key points. You can kind of see the 2D image over here on the right. Notice how the papillaries are kissing. They're called kissing paps. I coined that phrase about 15 years ago, and it was stolen from me. And I'm somehow trying to get my name on whatever Young Doctors Network that they keep talking about it with as my phrase. But a quick eyeball EF, you get wall motion abnormalities, you get volume status, quick and easy, down and dirty with this view. It's a very nice view. And a slight tilt offers views of the mitral valve. And then if you push it a little bit towards the sternum and go a little bit more cephalad, you can get a nice view of the aortic valve as well. Again, we're talking 6 different positions with the FADE exam, but you can carry it out as far as you want, and you'll find that this is a very good tool, and you probably will never use your stethoscope again. Parasternal long axis, you're just rotating 90 degrees. It's in the same spot, left parasternal border, but the index marker is pointing toward the right shoulder instead of towards the left shoulder. Your sector depth is about 10 to 16 centimeters. The handhelds are very nice, and some of the presets and some of the Sonus sites are very nice as well as just going ahead and setting you up with the correct sector size and depth and everything else, penetration versus resolution, this and that. So I encourage you to explore the different knobs on your console. So this is the parasternal long axis, and what you've got is you've got a very nice cut right through the ventricle in this 3D view, and in the 2D view you got a nice view of the right ventricular outflow tract, the left ventricle, mitral valve, aorta. Descending aorta is over here. If you've got a pericardial effusion, it's going to be down here. If you've got a pleural effusion, it's going to be over here by the descending thoracic aorta. But you can look at anterior wall, inferior wall, you can look at the ventricular septum. If you've got some type of septal hypertrophy, you've got it right here in this septum, and usually this septum is nice and big. So what are you doing? What information are you getting from this view? You're looking for pericardial fluid or tamponade physiology. You're looking at RV, LV size, but also this RV, again, this is not a very good conclusion. This is actually mostly right ventricular outflow tract. But if this is huge, you're thinking that you've got some RV hypertrophy. Is the septum normal and moving normally? Is the LV beating pretty well? This is a very qualitative assessment. But if the LV is down, you can really tell. It's usually pretty obvious. And so you're making a yes-no assessment here. But this is a very good view for me for looking at the mitral valve leaflet. And I can also put some color on here and see color during systole, which tells me that I've got a pretty good bit of MR. And I'm not saying we got trace or mild MR. It's either trace mild or moderate severe. It's a yes or no equation. So some of the key points with the parasternal long axis, the best view for measuring chamber dimensions. You can actually measure these dimensions here, and you can also measure the wall thickness and get a good idea about what's going on with your LV. Doppler offers a quick look for aortic stenosis. You can put some Doppler right across this aortic valve. You can look for AI. You can also see a very turbulent flow and high velocity, which means you've got AS. You can also see some backward flow during systole, which tells you that you've got mitral regurgitation. It's kind of hard to pick up any MS, but you can pick it up in some prosthetic valves as a big jet, high velocity jet. And you can get into some other things if you really get the hang of it, like a continuous wave and pulse wave Doppler. But it's a very high utility view. All these views are, it may seem like a lot to you right now, but it's just 6 little views. So pleural assessment, you're putting the transducer on the lateral thoracic wall at about the 10th rib or so on the left side, 10th or 11th on the right. I like the phased array. If some of my colleagues do a lot of pulmonology and ER stuff like the curve and linear, but again, this is just, I'm using one probe and I'm getting it done in a hurry. I don't know about you, but I don't have a lot of time to do a 20-minute scan on somebody. The scan is initiated posteriorly in the upper abdomen with the orientation marker cephalad. And the scan slid cephalad until the diaphragm is visible. And you're looking for relevant anatomy. You're looking for spleen and diaphragm on the left and liver and diaphragm on the right. And typically you're looking for effusion. Is what you're looking for. And this is something that, you probably need to have the patient set up a little bit. Not necessarily just straight up and down, but maybe a little bit of semi-recumbent position. So if you've got A lines, you've got you're putting your transducer on the chest wall. You've got the pleural line here where the parietal pleura and the visceral pleura meet, and you've got reverberations because really this is the lung, and so you're not really going to have a lot of anything to bounce off of, but you're going to get reverberations from the sound waves. But what happens if you've got some fluid-filled alveoli? Then you start to see some a little bit of change in conduction, a little bit of acoustic impedance, and you get these things called B lines, and these are nice vertical lines as compared to horizontal lines. These vertical lines typically go all the way down to the end of the sector, and if you got more than 3 B lines, you're typically considered to have pulmonary edema. So this is a pleural scan. You can see you're about your over here on the left side in the 3D image. You can see you're about the 10th inner space, and you can see here you've got the lung, you've got diaphragm, and you've got the spleen, and you've got the pleura. You can see the diaphragm excursion here. You can see a little curtain there of the lung coming down. That's not a B line. That's actually just a little curtain, and you don't see any anechoic region here at all. So you look for a curtain sign. So there's a lung block visualization of the deeper structures. Is there a mirror image artifact? If you're looking on the left side, you're looking for the liver, and we'll do that to a large degree in the FAST exam. And you look for a spine sign, which is the spine's usually not seen above the level of the diaphragm. Often you see this on the left side if you've got or the right side if you've got a right-sided pleural effusion. This is the patient with some B lines. On the left inferior, and you can see where you've got your probe, and you can see you've got some B lines kind of scattered in through here, but it's not very many. I wouldn't really consider that to be a sign of anything. But you've got some nice pleural sliding over here as well. Pleural sliding is indicated right here, so you know you don't have a pneumothorax. So this is a left pleural scan. in position 4, and you see you've got the probe on the left side, you've got the spleen, you've got the pleura, and you got the diaphragm, but you also have this anechoic region here, and you've basically got some fluid there that is probably leading to a little bit of low oxygen saturation, shortness of breath, hypoxemia, this and that. And typically you're going to have these in the more dependent regions when you're scanning. This is a left superior pleural scan, and what you see here around the second to third intercostal space, about mid-clavicular, you're going to be looking for, there's the parietal pleura here, there's the visceral pleura, and here's the pleural line, and you're going to get some sliding here, or marching ants. And what that tells you is that you've got sliding, so the lung is actually moving. If you had a pneumothorax, you wouldn't see this sliding. So in this patient, you've got no sliding at all. You see you've got almost a little lung pulse from the heart beating. So you have lung pulse, no sliding. You probably have a pneumothorax, and you have a high probability of pneumothorax. It's probably about 90% sensitive for it. And there's parietal pleura, visceral pleura. You typically see an effusion in the bases, as we talked about. You may not necessarily see it here. You may see some consolidation if you really have some bad pneumonia, but typically you're not going to see that here. Again, this is second rib, second to third intercostal space, mid-clavicular. So chamber dimensions. Normal ranges for LV internal dimensions. The diastolic dimension is 5 centimeters for males, 4.5 for females. Systolic is 3.2 centimeters and 2.8 respectively. And then normal ranges for LV indices. For wall thickness, it's typically 2.4 to 4.2 for males and 2.2 to 4.2 for females. Septal thickness, it's 6 to 10 for males and 6 to 9 for females. And posterior wall is 6 to 10 for males and 6 to 9 for females. So basically, you can tell from these indices whether or not you've got any type of chamber dilation and whether you've got any wall thickness. And you think, well, God, man, that's too much information to remember. That's why you've got your fate card. There's a little small foldable card you can stick in your shirt pocket, or else there's an app on your phone now that is very nice as well. And you can get these quick measurements if you even have a handheld. The handhelds can do this as well. Contractility and LV function. Normal EF is about 55%. Mild LV dysfunction is the EF 45 to 54%. Moderate LV dysfunction is 30 to 44%, and severe is less than 30. And you can get something called fractional shortening by taking the dimensions either by using M mode, as you do here, or and in this case I measured the different measurements in systole and diastole. The measurement during diastole was 7.1, the measurement during systole was 4.6, and then I divided it by the measurement during diastole, and it was 35%. So this fractional shortening times 2 is your EF. But to be honest, most of us use eyeball EF because we're not trying to say the EF is 70% or the EF is 55%. We're saying it's either good or bad, because how does that change your anesthetic? Well, it means you don't overpressurize your volatile. It means that you may be wanting to use a little bit more fentanyl instead of volatile. It means you're using ephedrine instead of neo. Maybe you're using norepinephrine instead of neo or ephedrine. And it may be you want to get some baby epinephrine around. Maybe it means that you're a little bit more tame with your volume resuscitation, things like that. So chamber dimensions, contractility, and LV function with LV classification with LV dysfunction. LV diastolic chamber dimensions of 8, systolic dimensions of 7. So if you take these numbers, 8.1 minus 7.1, and then divide by 8.1, your fractional shortening is 12.3. You double that, and your EF's 25%. Now, do you really need that when you're looking at this chamber, and you're looking at the chamber width here, and you're seeing how much moves here? Not really if you're using M mode. And in 2D, which we'll look at a little bit later, you'll see that it's usually pretty obvious. So this is a view, short axis view, and you can kind of see where you got some anterior wall hypokinesis. This is just not moving very well compared to this and compared to this. So you've got normal wall thickening. here, mild hypokinesia, severe hypokinesia, akinesia, as far as basing this on numbers. But to be honest, you're looking at it and you're saying, you know what, that just isn't beating very well at all. Often you can get a nice effusion. If you're looking for an effusion, you often like to measure this. Typically, a centimeter and a half is something that you're wanting to go to the OR for. Anything a centimeter or less, you're pretty much not doing a whole lot with because it's hardly worth sticking a hole in somebody for. But a mild effusion is less than a centimeter posterior to the heart. Moderate is, like I said, 1 to 2 centimeters or 10 to 20 millimeters, and then large is greater than 2 centimeters circumferentially. So fate findings are with tamponade. If you work in a trauma service, you see this about 10 or 15% of the time you have unexplained hypotension. You have right atrial or right ventricular diastolic collapse. You can see the right ventricle here is kind of collapsed because it's underfilled. You have septal bounce. You have LV diastolic size that varies during inspiration, sort of like if you put your finger on their pulse and the pulse goes away during inspiration. It's the same thing with echo. And then you have lack of IVC variability during inspiration and sniff, even though the numbers are up there. So opposed to failure and opposed to tamponade, you have hypovolemia. And again, sticking a probe just directly on the parasternal short axis, you get a nice view of the kissing paps. You get a nice view of wall motion, ejection fraction. And you think, wow, man, the ejection fraction here is 80%. Well, that's because you're very underfilled, you're under-resuscitated. So typically you're going to have a left ventricular end diastolic diameter of less than 2.5 centimeters, and your left ventricular end diastolic area is going to be less than 10 centimeters with almost complete obliteration of the LV cavity. And these are just numbers. A lot of what you do with the FADE exam is going to be qualitative assessment. But unfortunately, until you really get a lot of experience with this, you're pretty much obliged to go by numbers, especially if you're handing over or if you're dealing with multiple people, especially a surgeon, and you're telling them what your findings were. Heart valve dysfunction. You have stenosis, regurg, restriction of the leaflet, thickening, calcification. Often you have some type of prosthetic leaflet that's not moving very well, vegetations, prolapse, and a flail leaflet. And in this patient, you can see this valve here, this mitral valve leaflet is prolapsing. And if you put some color on it, you'd probably see a pretty good bit of regurgitation. And you think, well, which leaflet is this? It doesn't really matter. But if you can find the aortic valve, the leaflet next to that is typically the anterior leaflet. I'm saying that this is the posterior leaflet. So you've got some mitral prolapse, and you're going to refer them to a cardiologist. Or you can go ahead and get some color on it and make an estimate of trace mild versus moderate severe, but you're not going to call it 1, 2, 3, or 4 plus. You're just going to say yes or no. Aortic stenosis, you typically have in this three-dimensional view, you can see the aortic valve not moving very well at all. And then you see this very hyperechoic aortic valve that is not opening very well at all. You can put some color on there as well, and you can probably see a pretty good velocity across there, a high color change, but you're also going to see very thick walls here. Notice the thickness of this anterior and inferior wall. You can also look at your mitral valve while you're here as well. But typically in the patients that we're taking care of, the older patient population that present for surgery, they have some type of calcific or senile aortic stenosis. It's typically not rheumatic fever. We don't have a lot of that in this particular country. If you're trying to assess aortic insufficiency with Doppler, you're going to get again, you see in the 3D view what you're scanning. You see you put a little Doppler on, you got a nice bluish color change here and a little color flow during diastole, which you're not supposed to have color flow across the aortic valve during diastole. It's often misinterpreted, but based on the percent of the left ventricular outflow tract, it usually has to be a very brisk flow to be considered clinically significant. And if that's the case, then and you've got significant aortic insufficiency, you're going to refer them to a cardiologist. As far as your anesthetic management goes, you're probably going to avoid extremes of heart rate, especially bradycardias. Mitral insufficiency, you can see you've got blood flow during systole here across the mitral valve, which you're not supposed to have. You got a nice coandal jet there. Degree of regurgitation is qualitative. You're not trying to do any type of really fancy continuous wave or pulse wave Doppler or any of this other stuff with the fate exam. But you're going to refer this patient to a cardiologist probably if they've been having symptoms, if they're having shortness of breath. You're probably going to cancel surgery. What you can do, though, is you can freeze this image and measure the more narrow part of this regurgitant jet, and if it's greater than 0.4 centimeters, it constitutes moderate severe MR and probably somebody that does not need to be undergoing an elective operation. If you're forced to do the operation, obviously in the absence of coronary artery disease and the aortic stenosis, you're going to want to maintain a pretty, brisk heart rate, probably 70 to 90 beats per minute, and avoid extremes of hypertension. TR, tricuspid regurgitation, can also be seen with Doppler. You can see the tricuspid valve over here, and you see a nice tricuspid regurgitant jet. Tricuspid valve is supposed to be competent during systole, but obviously it is not in this patient. But again, it's very qualitative. It's yes or no. It's mild, trace mild to moderate severe. So I'm saying that this is moderate to severe tricuspid regurgitation. You can actually use this TR jet, you can measure it with Doppler, and then you can actually calculate the pulmonary artery systolic based on that. It's something that if you start to really get into a lot of echo, you do, but not for the purposes of the simple fate exam. And this is a patient with an acute PE. Typically, the qualitative findings, you have RV hypokinesis, so the right ventricle is not beating very well. That should be pretty obvious. It's also twice the size of the LV, so you've got an underfilled LV. You've got a free wall of the RV that's not beating well, McConnell sign where the apex is spared but the RV is not, and you got the septum that's kind of going the wrong direction. And typically, you look at the RV to LV ratio, which is obviously greater than 1. And you can measure the RV end diastolic diameter, but you don't need any of this stuff to say that RV is sick. You also see all this tricuspid regurgitation here, blue, away from the transducer, which is up here. So in summary, the focus assessed transthoracic echo or fate exam provides assessment of ventricular function, volume, and gross valve pathology. Additional pleural scanning through the fate protocol provides context-rich assessment to correlate with your clinical findings. It's there to assist you much in the same way a stethoscope is. If you really are proud of your skills with a stethoscope or reading a chest x-ray, it's no different than that. It's not something you have to do, but the more you do it, the more of a skill set it becomes, just like interpreting chest x-ray, just like interpreting pulmonary function tests, just like using your stethoscope. And the fate exam provides some basic information in pactic anesthetic management. The more you use it, the more comfortable you are with your assessment. This is actually a 3D echo I did on myself about 4 or 5 years ago, and I showed it to my students, and they all looked at it and saw the EF was 58%, and they said, "Oh, dude, your EF's down." So anyway, thank you very much for experiencing this presentation.